Our next speaker is Dr. Sasha Tuchman from the University of North Carolina. As I said before, graciously, heroically stepped in to do a complicated but exciting topic at the very last minute because our original speaker, who you all saw in the original mailings, wasn't able to make it. So Sasha, thank you so much for coming to talk to us about RNA interference therapy today.
Great. Thank you all for being here, and thanks to Jeff and Silva for organizing and for the introduction. And so we are going to change gear a little bit in that we've largely focused on AL, and I think the concluding part of Jeff's talk, where we sort of transition to TTR, was perfect for what we'll be talking about for the remainder of the symposium, which is largely TTR amyloidosis. And so I'll be talking about gene silencing therapies, and then my colleague John Burke will be talking about tetramer stabilizers and other aspects of TTR management after me. And so in terms of relevant conflicts of interest, consulting for Alnylam, I will be talking about some of their products today, and then also research support from Prothena as well as Alnylam. And so to back up just a little bit and provide a little bit of background, we haven't talked much about TTR pathogenesis, where this comes from, and why this really has nothing to do with light chain amyloidosis, which again has been largely the topic of today. So as a reminder, TTR stands for transporter of thyroxine and retinol. So TTR is a normal protein that all of us have. It has a physiological function we think of basically stabilizing thyroxine or thyroid hormone and retinol, which is vitamin A in the blood. And so TTR we know is synthesized by the liver. Jeff alluded to this, but basically it's synthesized in the liver as monomers, so single pieces, and then 4 of these monomers come together and form these tetramers that you can see here that are secreted into the blood. It's that tetramer that has the normal physiological function of then stabilizing, again, thyroxine and retinol. And again, under normal circumstances, in some patients more than others, some of this TTR tetramer dissociates in the blood back into the monomers that were originally synthesized in the liver, and it's these monomers that have the predisposition toward depositing in different organs and forming amyloidosis, as you can see at the end of this cascade. And so if we look at how this can happen in different patients, big picture is that this can happen under normal circumstances with unmutated TTR protein, and then separately in other patients it can happen with mutated versions of TTR. So on the left you can see normal liver synthesizing wild type or normal TTR protein, and then when patients develop amyloidosis related to this, it's typically an isolated cardiomyopathy that occurs in older males, as we'll see in a second. Conversely, in hereditary versions of TTR amyloidosis, patients inherit abnormal versions of the TTR protein. This results in mutant TTR that circulates in the blood, and depending on what the mutation is, this abnormal TTR can have a predilection toward depositing in the heart and causing cardiomyopathy, or in different nerves causing a neuropathy. And so when we look at this clinically and what the different phenotypes are that we see, basically we can break it down into cardiomyopathy versus neuropathy. For forms of amyloidotic cardiomyopathy, we have, again, wild-type TTR. So that's, again, normal TTR, and historically we've called this senile systemic amyloidosis. No one likes being called senile, so we don't use that term much anymore, and rather it's wild-type ATTR cardiac amyloidosis. And then conversely, as mentioned, some patients have mutated versions of TTR that are more likely to deposit in the heart, and we call this familial amyloid cardiomyopathy, or FAC. And then other patients have different mutations that again have a much greater predisposition toward depositing in nerves, and this is called familial amyloid polyneuropathy, or FAP. And we will talk about these in different contexts throughout this talk. So in terms of what we see clinically, wild-type TTR cardiomyopathy is relatively common and probably relatively underdiagnosed, and in fact, it may be one of these conditions that all of us, at least men, get if we live to an old enough age. So there have been autopsy series that have looked at this in older patients who have died of other causes, and in people above 80, 25% of autopsied hearts had some level of TTR that was found in them. However, only a third of those had actually what was felt to be clinically significant deposition. So about 8% of patients in total, which is still almost 1 out of 10 people, had amyloidosis and they didn't know about it before they passed away. When we look at what we actually see in patients who are alive, this is typically a relatively indolent form of cardiomyopathy that presents almost universally in men above 70, so there's a 9-to-1 male to female predisposition to this. And again, as mentioned, this may be one of those things that all men develop if we live long enough, such as things like prostate cancer. As far as mutated versions of TTR amyloidosis, this is really one of the fascinating aspects of this disease, in that they're all abnormalities in the same protein, but depending on what that abnormality is, the phenotype for the patients can be completely different. And you see this on the spectrum listed here, where sort of along the arc of this circle, you see the different mutations that we see in patients. And on the right, we have patients with a predominantly cardiac phenotype, versus on the left, we have patients with a predominantly neurologic phenotype. And say, for example, the Val30 MET mutation, which is one of the more common ones seen worldwide, the early onset version of this is almost entirely a neuropathic presentation. Versus the V122I mutation that we see here on the right, this is the form that we see much more commonly here in the United States of familial amyloidosis, and this is almost universally a cardiac presentation. But there really is a spectrum to this, in that you have some of these mutations on the top left where patients may have a predominantly neuropathic presentation, but they develop cardiomyopathy later in the disease. And then conversely, on the top right, we see patients that have mutations that cause a much greater predisposition toward causing cardiac amyloidosis, but again, develop neuropathic manifestations later in the disease. So again, same protein, but different mutations dictate the different clinical phenotype. And so if we look at familial amyloid cardiomyopathy, or FAC, this is a very real problem here in the United States. And in fact, it's by far the most common form of inherited amyloidosis that we see here in the United States. The classic mutation that we see is V122I, which is carried by 3 to 5% of African Americans here in the United States. But it's important to recognize that this mutation has an incomplete penetrance, meaning that not everyone who has the mutation gets the disease. So this has been looked at in a fairly large study in the New England Journal. This was part of a prospective study looking at cardiac disease. And basically, they looked at patients that had the mutation versus patients that didn't have the mutation. And importantly, there was no difference in mortality between those two patient populations over 21.5 years. And there was a suggestion of early markers of heart failure being increased in patients with the mutation. So they looked at things like echocardiographic findings, pro-BNP elevation. And although those were more present in patients with the mutation, there was a relatively low prevalence of actual clinically significant heart failure in patients that had the mutation. So again, an important point from this is that having the mutation does not mean that you will necessarily get the disease. And in fact, most people that have the mutation probably will not get the disease. Moving on to familial amyloid polyneuropathy, so this is extremely rare here in the United States, and worldwide it's relatively rare. This is a disease that's seen predominantly in certain countries, namely Portugal and Sweden, largely due to founder effect. And again, worldwide this is relatively rare, but depending on certain parts of those countries, or where we are in certain parts of those countries, prevalence can be as high as 1 out of 600. So it is rare worldwide, but again, relatively common in certain parts of the world. In terms of the clinical manifestations, so for cardiac amyloidosis, of course, they get progressive congestive heart failure. Median life expectancy from time of diagnosis is 2 to 10 years, depending on whether or not they have mutated or wild-type cardiac amyloidosis, and then also severity of symptoms and clinical phenotype at presentation. It predominantly affects men greater than women, but women can get this condition also. And there's a fairly variable age of onset. So wild-type cardiac amyloid typically presents in men above 70, whereas familial amyloid cardiomyopathy can present at a younger age, so in adults above 50. And again, typically African American in the latter case. And then for familial amyloid polyneuropathy, this affects typically all nerves, so it causes a progressive sensory motor and autonomic neuropathy. Age of onset can vary. In certain populations, age of onset can be 20 to 30, versus in others, they can present later in life and mid-age. And the median life expectancy from time of diagnosis for this condition is typically 10 to 15 years. And so moving on to therapy, so the topic of this talk is really looking at RNA therapeutics for this disease. It's helpful to, again, just very briefly review the pathogenesis, which is that TTR starts in the liver, it's synthesized and comes out of the liver as those tetramers. Those tetramers then circulate in the blood. The tetramers dissociate back into those monomers, and it's those monomers that can then deposit in different organs and form amyloid. And so when we think about different ways to perturb this and interfere with TTR pathogenesis, one, of course, logical way to do this is to reduce TTR production. So we'll look at ways to do that. Another element or another area of research has been TTR stabilizers. So you've heard a little bit about this before. We heard a little bit about some of the medications that are used to do this, but basically these are different drugs that are thought to go into the blood and basically stabilize that TTR tetramer in the blood so the tetramer can't fall apart and there are fewer monomers available to deposit in the organs and form amyloid. And then finally, as you heard already, doxycycline, some of the antibodies that Jeff talked about, there's a lot of interest also in these antifibrillary agents. So what can we do about the amyloid that's deposited in tissues already? And so if we look at where we are with this currently, reduction of TTR synthesis has been primarily accomplished via liver transplant. Not in wild-type TTR, of course. Doing a liver transplant in someone with wild-type TTR is not going to help anything, but this has really been done for patients with mutant TTR, with the idea that this liver is making abnormal TTR protein that's much more likely to form amyloidosis. If you take that liver out, give them a normal liver that's now making normal TTR, can you affect the course of the disease? We don't have time to get into this today. The answer is yes, but it's clearly not a home run. What we are going to focus on is novel RNA therapeutics, which are basically new drugs that cause the liver to stop synthesizing TTR. In terms of TTR stabilizers, again, my colleague John Burke is going to talk about this after I complete my presentation today. Tafamidis is approved in Europe for familial amyloid polyneuropathy, probably on the cusp of approval here in the United States for different forms of TTR cardiomyopathy. And then we have diflunisal, which again, Dr. Burke was involved in developing, and we often use this off-label as a TTR stabilizer in patients with TTR amyloid. And then finally, you've heard a little bit about the antifibrillary agents, doxycycline. We went through it in depth already. EGCG is green tea extract. There's some data for this. And then TUDCA, we really haven't gotten into this today, but basically that's an amino acid supplement. And all of these are thought to have some activity in interfering with the TTR fibrils once they're in tissue already. And so again, to turn our attention to inhibiting TTR synthesis by the liver, there are now 2 approved agents within the last year. So inotersen, which we'll look at by Ionis, Axia, and then also patisiran, which is made by Alnylam. Then in terms of investigational approaches, TTR-LRx is coming, TTR-SCO2 is probably coming, and then there are other approaches which we really won't get into today. But it's helpful to understand a little bit about how these drugs work and mechanism of action, and this is really part of the cool aspect of development of these drugs, in that the biology behind this is really neat. It's great that they work, but when we think about how they work, it's really neat stuff. And both of these basically interfere with mRNA translation. So basically the mRNA that's in the cytoplasm of the cells that's being translated by ribosomes into TTR protein that then goes into the blood. Both of these drugs interfere with that. So on the left, we have antisense oligonucleotides. On the right, we have small interfering RNAs. In terms of antisense oligonucleotides, we have inotersen, which again is the drug that's been approved. This drug goes in subcutaneously, makes it into the liver cells. This antisense oligonucleotide then binds to mRNA, which then inhibits TTR synthesis or TTR translation, resulting in less TTR coming out of the liver and circulating in the blood. siRNA or patisiran works by a similar but slightly different mechanism. This siRNA comes into hepatocytes as a double-stranded molecule, complexes with this molecule called the RNA-induced silencing complex, or RISC, and then this entire molecule then basically tracks down TTR mRNA, binds to it, and primarily leads to mRNA degradation, and otherwise interferes with TTR synthesis. So the end result of both of these drugs is reduced TTR synthesis by the liver. So to go through the 2 papers that have basically gotten these drugs approved, we'll look at inotersen first. This is a study called the NEURO-TTR study, and it's basically a classic randomized pivotal phase 3 study. So this was a study done in familial amyloid polyneuropathy. Patients could have cardiomyopathy also, but they had to have neurological impairment to participate in the disease. And basically, they had to have what I would characterize as mild to moderate impairment. They had to have some neurological deficits, but they couldn't be so impaired that it would be too dangerous for them to go on the study, and basically this meant less than wheelchair bound. One other element of the eligibility criteria included this neuropathy impairment score, and I'm assuming that there are relatively few neurologists in the room who know what this means. I had to look it up myself, even though I participated in the study. And the neuropathy impairment score is basically a way of quantifying neurological deficits. So it's based on a neurological exam. Based on what the neurologist finds, patients get a score. As you can see here at the bottom, the score ranges between 0 and 244. Higher score is worse. And patients who went on the study had to have a baseline score of 10 to 130, which kind of medium range, so mild to moderate disease. Again, as said, patients could have heart failure. It was not required, but could have heart failure. It just couldn't be too severe. And then for patients to participate in the study, they couldn't have had a prior liver transplant, and they could not be on a stabilizer at time of study participation, but they could come off a stabilizer to participate. In terms of how the trial was designed, again, classic randomized study. So patients were randomized 2-to-1 to receive the study drug inotersen, given as a 300 milligram sub-Q weekly injection, versus placebo. They received it for 15 months, and then all patients after conclusion of their participation in the study could go on to an open label extension, where again, open label, and all patients got the drug for up to 18 months. And the study was stratified by presence of the Val30 MET mutation versus other mutations, disease stage, and then also prior tetramer stabilizer use. Unsurprisingly, the primary endpoint for the study was improvement in neurological function at the end of study participation, so at week 66 in this NNIS+7, which is basically just a modified version of this neuropathy impairment score that I mentioned earlier, and then also a validated quality of life questionnaire, which has been looked at primarily in diabetes, but has been accepted as valid in amyloidosis also. Secondary endpoints, of course, included other markers of neurological function, biomarkers, and then I do want to point out that one critical element of both this and the next study that I'll talk about is that they were both double-blinded and and the assessments were centrally completed. You can imagine that there could be quite a bit of subjectivity on a study like this if patients or the people studying their neurological impairments know what they're getting. And so baseline characteristics between these two populations were fairly similar. I won't go through these in detail, but age, presence of Val30 MET versus other mutations, baseline neurological impairment, prior stabilizer use, quality of life at enrollment. And the one thing that was a little bit different between the two groups was the presence of cardiomyopathy. 67% of patients with inotersen had cardiomyopathy versus 55% of patients on placebo. And looking now at the primary endpoint, we see the mNIS+7, so basically neurological function on the left versus quality of life on the right. Higher is basically worse, and what you can see here is that placebo, which is the black line on both of these graphs, clearly got worse over the course of the study, so this is 66 weeks at the end, versus inotersen, where things remained relatively stable. So in placebo, they worsened by about 25 points. And in talking to multiple neurologists about what this point scale means, it's not exactly clear. If you have talked to 3 neurologists at the same time about this and they disagree on what this means, but it's generally accepted that a 2-point change in this scale is the minimal clinically meaningful change detectable. So a 19.7 point difference, or 19.7 point difference between these two at completion of the study is a fairly significant difference, statistically as well as likely clinically. And then quality of life was also relatively stable in patients on inotersen versus patients on placebo, where quality of life clearly got worse. Importantly, the benefit was independent of stage, mutation, prior use of TTR stabilizers, and also the presence of cardiomyopathy. And then there was a subgroup analysis looking at patients with cardiac amyloidosis in addition to their neuropathic amyloidosis. And what they found was that there was no change in cardiac markers after 15 months on the study, looked at by things like longitudinal strain on echocardiogram and then also blood work like pro-BNP levels. Safety was a big topic of discussion with the study. Thrombocytopenia was relatively common. 54% of patients on inotersen experienced a platelet count of 140, so what we would call mild thrombocytopenia, versus 13% on placebo. But this got quite a bit of attention after one patient died from fatal intracranial hemorrhage with a platelet count of less than 10. There were also 3 episodes of glomerulonephritis in inotersen, which is an interesting side effect to see. After these episodes happened, the sponsor increased surveillance via more intensive CBC monitoring and also monitoring of renal function, and basically severe side effects went away after this intervention. Platelet counts still dropped, renal function still got worse in some patients, but they were easily and quickly reversible with temporary discontinuation of the drug. Otherwise, the drug was relatively well tolerated, mild GI side effects, fever, fatigue, and skin reactions. And so in terms of dropout, 22% of patients dropped out on inotersen versus 13% on placebo. And then if we look at deaths, there were 5 deaths on the inotersen arm versus 0 in the placebo arm. And the deaths in the inotersen arm were largely due to progressive TTR, and then there was the 1 bleed that I've mentioned already. And so as a result of this study, this drug has been approved in Europe, Canada, as well as here in the United States. And so if we turn our attention now to patisiran, that's the siRNA drug that we looked at earlier. This was a study called Apollo. And so very similar eligibility criteria to the last one. Again, I don't need to go through this in detail. It's basically patients with familial amyloid polyneuropathy, relatively mild to moderate disease, could have heart failure but not too bad, and couldn't have had a liver transplant and could not be on stabilizers at the time of study participation. Very similar structure to the prior study. Again, 2-to-1 randomization to study drug versus placebo. The duration of the study was a little bit longer at 18 months as opposed to 15 months for the neuro-TTR. And then after completion of this, again, blinded study, patients could go on to the open label extension, and similar stratification to what we saw with the inotersen study. Endpoints for this study, again, very similar. The mNIS+7 was, again, the primary endpoint for this study, much as it was in the last one. The quality of life endpoint on this study was a secondary endpoint as opposed to primary on the last study, but otherwise this study was very similar to the other one. Baseline characteristics also pretty similar. The one difference that sticks out is that there was a slightly higher percentage of patients on placebo who had the Val30 MET mutation, as opposed to only 38% of patients on patisiran, but otherwise age, baseline neurological dysfunction, and presence of heart failure were all pretty similar. Primary endpoints, so mNIS+7 is on the left, Norfolk quality of life diabetic neuropathy score is on the right. Again, higher is worse. Gray line is placebo, blue line is patisiran. And so if we look at neurological impairment, again, much like on the prior study, patients on placebo had fairly significant worsening of their neurological function over the 18 months of study participation, and patisiran had stabilization, if not a little bit of improvement here. And especially when we look at the delta here, there's a pretty tremendous difference between these two sets of patients at the completion of the study. Quality of life also, unsurprisingly, was much better in patients on patisiran as opposed to placebo. And placebo, they clearly got worse. Patisiran, stable to maybe a little bit improved. And again, much like the prior study, benefit was independent of disease stage at diagnosis or disease stage at presentation for the study, presence of the Val30 MET mutation, prior use of a TTR stabilizer, or the presence of cardiomyopathy. And in this study, interestingly, this was hardly definitive, but when they looked at patients who had cardiomyopathy in addition to their baseline neuropathy, there was a suggestion of cardiac improvement when they looked at things like NT-proBNP and echocardiographic findings. So again, I want to emphasize not definitive, but an interesting signal there. Safety for this was pretty boring in a good way. So mortality was 5% on patisiran versus 8% on placebo. And it's interesting to look at this in the sense that if you look at what actually happened, again, this is not statistically significant and tough to make out definitive conclusions from small groups of patients. But if we look at what patisiran patients died of, it was primarily cardiac causes, sudden cardiac death, other arrhythmias, things of that nature, versus various causes for placebo, but not a whole lot of cardiac mortality. But if we look at overall incidence of any cardiac events, including, of course, non-fatal ones, we saw that there was actually a lower incidence of these in the patisiran group versus the placebo group. So 28% for patisiran versus 36% for placebo. In terms of other side effects, patisiran caused mild peripheral edema, very mild infusion reactions, all of which were easy to manage, and relatively low dropout of 7% for patients on patisiran versus 38% for placebo. And so this study similarly resulted in the drug being approved in Europe, Canada, and here in the United States. And so to wrap up, I think it's helpful to think about where we are now and where we're going with all of this, and that this is really a tremendously exciting time for amyloidosis in general, and specifically TTR amyloid, because until now we've really had almost nothing. These are the first two drugs that have been approved here in the United States for treating TTR amyloidosis. But the question is, how do we translate this clinically at this point? And so one major question in that both of these drugs have come out not exactly at the same time, but pretty close, but how we choose inotersen versus patisiran. It's really a tough question to answer. The studies were, of course, not head-to-head. Inotersen was only for 15 months. Patisiran was for 18 months. And so a lot of it has to do with convenience, what's available, things of that nature. But it's very hard at this point to say for sure that one drug is better than the other, or that we should be preferentially using one in patients versus the other. And then one major question, of course, or one significant area of interest for people who do this is how do we combine this with what else is available? So as we looked at earlier, this only interferes with one aspect of TTR pathogenesis, which is to temporarily suppress TTR synthesis by the liver. As we've discussed earlier, and as my colleague Dr. Burke will discuss in a minute, there's other aspects of TTR pathogenesis that we can interfere with. TTR stabilizers can stabilize TTR in the blood and prevent it from reaching organs. And then we have this exciting new data looking at antifibrillary agents, which may be even able to help break down TTR that's in tissue already. So how do we combine these drugs that I'm talking about now with this new stuff that's in some cases available now or coming in the very near future? Lots of research, but we really don't know the answer to that currently. A question that's really here and now is what about amyloid cardiomyopathy? So here in the United States, cardiomyopathy is far more common than neuropathy as a manifestation of amyloidosis, and it seems like a no-brainer. You know, cardiac amyloidosis is caused by TTR in the blood. We can give these drugs. We can shut down TTR synthesis by the liver. So of course, it's going to help patients with cardiomyopathy also. And in fact, if we look at the patisiran study, there's a suggestion that maybe these drugs really are good for patients with cardiac amyloid. But this is really not a no-brainer, and we need to tread cautiously if we think about especially the revusiran experience. So revusiran is something that's not much talked about nowadays, but it's a drug that we were very excited about a couple of years ago, another RNA drug by Alnylam, which is the same company that makes patisiran, and this was directed at patients with familial amyloid cardiomyopathy. And this study was actually halted early due to excess mortality in the treatment arms, so in the patients on revusiran. So again, cardiomyopathy is not a no-brainer for these drugs. And when we think about kind of cost and other issues and and the fact that that mutant TTR amyloidosis has a relatively low penetrance, again, meaning that patients with the mutation, most of them will not get the disease, how and when do we start treatment in asymptomatic carriers? Most patients will not develop it, so when do we actually start treatment? And then, of course, these days we have to think about cost, optimal duration of therapy. Many patients with mutant TTR amyloidosis will be diagnosed in middle age, if not in their 20s and 30s. TTR synthesis is never going away, and so presumably these patients will need to be on some form of this therapy for life. 40 years is a long time to be on any drug, and we really don't know how to do that best. But I think perhaps the future is the most exciting thing to look at currently. We have next-gen therapeutics coming, so SCO2 is the next-gen version of patisiran coming from Alnylam. This will be a sub-Q injection Q3 months as opposed to the current patisiran, which is intravenous Q3 weeks. So a quarterly injection for patients would really be a game changer. Patisiran is already, but coming in once every few months just to get this injection and done would be pretty amazing. And then Ionis is also working on the next-gen version of inotersen. The LRX is coming. I'm not aware of what the dosing schedule is on that one. New stabilizers are coming, AG10, sort of building on the success of tafamidis and other drugs. AG10 is one that's coming that's in clinical trials. Jeff already talked about PRX004, so I won't mention that. But there is one thing, I know I'm a little, oh no, I'm not over, perfect. So there is one thing that I do want to mention, which is tremendously exciting in this field, and that's CRISPR. So CRISPR is an entirely separate discussion for a different day, but an incredibly exciting technology for basically modifying genes. And so for a purely genetic disease like mutant TTR amyloidosis, this is huge news. And so CRISPR, again, goes beyond the scope of this talk today, but just to kind of get into very briefly how CRISPR could be a game changer in this disease, I'd have to very briefly review protein synthesis in cells. And don't worry, this is going to be quick for those that are dozing off. So basically DNAs in cells, of course, DNA codes for proteins. DNA is then transcribed into messenger RNA. That messenger RNA then migrates from the nucleus into the cytoplasm where ribosomes attach to it, and then proteins are synthesized. And so if we look at how the drugs worked, we've talked about RNA drugs that basically interfere with the RNA aspects of this. They attach to that messenger RNA and through various mechanisms prevent that from eventually becoming TTR protein. But the problem, as you can imagine, and as I've alluded to earlier, is that this doesn't do anything about the source. So you can wipe out all that messenger RNA, but a couple days later, it's all coming back because that DNA source has been unaffected. CRISPR is finally a way of changing that. And so CRISPR is basically a technology that's delivered through various mechanisms. One way is by doing it via these lipid nanoparticles. You can pack these CRISPR molecules into these fat globules. They can be given through different routes. That eventually migrates into hepatocytes. The CRISPR is then released and gets into the nucleus where it does the job. And basically what that is, in this case, is that CRISPR can go, it's a very specific way of cutting out genes and otherwise editing them. So CRISPR, when we're looking at TTR, can go specifically to chromosome 18, to the TTR gene, and it basically chops out a piece of this exon 2, which is one of the critical parts of the TTR gene. After it chops that out, then the normal DNA repair mechanisms kick in, and it basically sutures those two broken pieces of DNA back together. But what happens is that there's a piece missing, and with that piece missing, this piece of this mRNA or this gene can no longer be transcribed. So it's all of a sudden a non-functional gene, resulting in no messenger RNA and therefore no more TTR synthesis by the hepatocytes. So this could be much more durable and real source control, unlike the RNA drugs, which are really kind of continually cleaning up the mRNA mess that's present in these patients. And so this has not yet been tested in humans, and this is very early data that I basically found online, but this is looking at CRISPR technology in non-human primates. And what they're looking at on the y-axis here is TTR levels in the blood, x-axis is of course time, and this is after a single injection into non-human primates with CRISPR versus the vehicle, or basically control. And what you see over the course of the month is a steady decline in the levels of the TTR in the monkeys versus, of course, no change in placebo. And then in other data that's been, again, very preliminarily discussed by this group, this effect was present even 6 months out. So potentially really long-term suppression of TTR synthesis using CRISPR to basically get rid of the gene that's causing the trouble in the first place. And with that, I will finish up, and thank you all for your attention.
Very